Kia ora koutou and welcome to tonight's Goodfellow webinar on recognising and responding to pain following surgical mesh surgery. My name is Dr. Courtney White, and tonight we will hear from two speakers, Dr. Karen Joseph, who is trained in pain medicine, obstetrics and gynecology, and sexual and reproductive health. She's the only doctor in Australasia with this expertise. We also have Dr. Jessica Mills, clinical psychologist, whose special interests include pelvic pain and pelvic treatment injuries, in addition to her work in cancer care. I'll now hand over to Karen. Thank you, Karen.
So my name is Dr. Karen Joseph.
And I'm Dr. Jessica Mills.
And tonight we're presenting the fourth in a series of webinars for primary health professionals, which is supported by ACC and the Ministry of Health, which aim to reduce harm by surgical mesh. Recordings of the previous three webinars can be found on the Goodfellow website. And we would like to thank the consumer representatives, Charlotte and Diana, and specialist GP, Dr. Geetha Cox, for their feedback during the development of this content.
And we also just wanted to sort of highlight that even though we've both had extensive experience in training in persistent pain, there is really no such equivalent training for mesh harms. And we don't want to position ourselves as experts in that area, but we do hope that you can learn from the experiences we've had in supporting people with mesh harms and pain, and understand that we are also still learning as we go.
So before we start, a few disclaimers. Through this webinar, we will use the term woman and she, her, but we recognise that not everyone who has pelvic mesh identifies with these. And as we are talking about surgical mesh harms, we will need to cover some really difficult topics. So please consider if now is the right time for you to watch this, as it will be recorded for later viewing, and please look after yourself. We're going to use a number of case studies through this talk, and while they are based around many of the things that we've seen, they are made up people. And we're really pleased if consumers are also interested in what we have to say, but please do not make any changes to your treatment plan without taking medical advice first. So we only have an hour tonight, and so we're not going to have time to delve into the details around specific treatment. We're also not going to look at the complexities around the ACC definition of surgical mesh injury and cover entitlements. Instead, we're going to look at pain and suffering following the use of surgical mesh within the pelvis, but we're also not going to have time to be able to cover everything that you need to know to be able to do this. We are going to try and give you some background to understanding pain, and to understand the whole person approach that we use and the philosophy of an interdisciplinary pain service. We're also going to look at a GP role in managing pain and suffering, including what you can try and manage to do in just a 15-minute consult. We're also going to look at a number of common pitfalls and how to try and minimise further harms. So a significant proportion of my current caseload is people who've been injured by healthcare, including mesh and other surgical injuries or complications. And sadly, many of these have also been inadvertently further harmed by treatments that were intended to treat their initial problem. And so we'll look at some of those pitfalls. We absolutely recognise that so many clinicians, especially GPs, do an awesome job on really minimal resources. And we hear so many positive stories about how our patients have felt supported and advocated for. But the spirit of the restorative justice process, which is what has led to this talk, is to reflect on and learn from when things have not gone well. And so we have chosen to focus on some cases where there are things to be learnt. And speaking of the restorative justice piece, I'd also like to take a moment to remind you that, as this quote by a consumer involved in that process highlights, surgical mesh is just one harm. The World Health Organization has identified that in industrialized countries, nearly half of all adverse events in hospitalized patients are related to surgical care, and at least half of those were considered preventable. We do really owe it to the sufferers of mesh harms to learn from and to not repeat the same mistakes, particularly as New Zealand has something of an unfortunate history in women's healthcare. So before I spend some time telling you what you should and shouldn't do, I thought it was appropriate that I give you some background as how I came to be here giving this talk. So as you can probably hear from my accent, I grew up and went to medical school in the UK, and I moved to New Zealand in 2005, just for 6 months to let the NHS settle down, still waiting. And in the intervening 18 years, I've had something of a hobby of collecting qualifications. When I first moved to New Zealand, I was living up in Hamilton, and I undertook sexual and reproductive health training. And I was under the supervision of the fantastic Dr. Jane Morgan, who was really the first clinician that I'd ever met to approach persistent pain any way than just the biomedical. But at the end of my training, Jane persuaded me that if I wanted to be able to offer more to women who live with persistent pelvic and vulvar pain, that if I just undertook the ONG training, that would really widen what I could do. So thus followed 6 years of ONG training, and while I certainly learned a lot, I really didn't meet anyone who knew anything more about managing persistent pain than Jane did. So it became a little bit inevitable that there was to be a third training program, something of an uphill struggle through pain medicine. But while I look back at my somewhat tortuous journey, it really is nothing compared to the journey that my patients have walked before they make it to my door. But one component of the alphabet soup that I've collected in letters after my name is FFPM ANZCA. And this gives me the title Specialist Pain Medicine Physician. And I'd like to highlight that this is a little bit different from pain specialist. There are lots of clinicians out there who use the term pain specialist. And in fact, there's no reason that any of you can't decide that you want to use this term. Because while there are some clinicians using this term who provide really great care, it's not a protected term. So any clinician can use it. So sometimes it's a little bit of the Wild West out there. At last count, there were just 37 SPMPs practicing in New Zealand. And so I'd be really excited if any of tonight's audience thought they might be interested in training. It's a post-specialist qualification, in theory a minimum 2 years, but it normally takes most of us longer than that because we work it part-time around our primary specialty. One of the entry criteria to the training program is that you need to have completed or be almost about to complete a primary specialty from this list. And I'd point out that specialist GPs are absolutely on this list and make fantastic SPMPs. So through this training, of course, I learn a lot about pharmacology and neuroanatomy, high-tech procedures, and the black magic behind how to program a PCA pump. But we also get a very clear understanding that pain and nociception are very different things. Nociception is just the transduction and transmission of an action potential resulting from a noxious stimulus and doesn't always cause pain. Pain, however, is always an unpleasant and personal experience, but it doesn't need any nociception to occur. And this understanding underpins the necessity of the approach needed when treating pain, which needs to be far wider than just the noxious stimulus. And as a result of this, the Faculty of Pain Medicine has renamed the biopsychosocial model, the socio-psycho-biomedical model, to really put front of mind the importance of the non-biomedical components. And another component of SPMP training is to learn to communicate, collaborate, and where appropriate, lead an interdisciplinary team. And as always, I do my best work with other members of my team, including Dr. Mills.
So now that we've oriented you to what a specialist pain medicine physician is and is not, let's talk about what a pain management clinic or program is or is not. It is not, unfortunately, a pain cure service, which is what many people are hoping it will be when they come to see us. But as the title suggests, these services are there to support people to manage pain. It's where we aim to work with people to live a valued and personally meaningful life with pain potentially, but without suffering. And we do this by understanding that the mechanisms of pain go beyond just nociception to include our physiology, our thoughts, our understandings about pain, our beliefs, our cultures, our social interactions, our sensations, our emotions, our past experiences, our behaviours, our attention, the environment, the context in which we have and have had experiences, our imagined futures, even what we might be wearing or how we move in our bodies, and the meanings we apply to all of these factors. Helping people to understand how all of these things can contribute to pain upregulation and downregulation, to stress and suffering. So it follows that within a pain clinic, we therefore aim to understand and increase those things that are modifiable to support downregulation and inhibit upregulation. This can include medicines and procedures for sure, but also supporting people to understand the nuances of their pain and then support them to use that knowledge in their individual situations in ways that optimize outcomes and empower them to improve their quality of life using a whole person approach. And for some people, that really does result in pain reduction, but that is never really the aim. The aim is always management and improving quality of life and reduction of suffering. And given that this approach is often very individualized and nuanced to every individual, it's important that all facets are targeted in really an integrated fashion to achieve optimal outcomes. Collaboration and tight communication between all clinicians and patients are crucial to ensure that we are working with shared understandings and shared goals and not inadvertently undermining part of that process. And in practice, this is actually really hard to achieve, particularly when most health professionals are really not trained to work in an integrative way with other disciplines, and when most centres are not at all adequately resourced to do so. And this just highlights how important integration in pain management is. IASP, the International Association for the Study of Pain, has made it their global focus for 2023. And if you want a really great framework to help you consider what you might want to include in a well-functioning IDT, or even in multidisciplinary or individual practices, the 5 I's framework developed by members of the Consumer Advocacy Alliance is a really great one to help us think about not just the things we need to be thinking about between the team and patients, but also between members of the team itself. So just thinking about who might be involved in a pain management team, other than, of course, a specialist medicine pain management physicians. The pain management team can include occupational therapists, physical health therapists, pelvic health physiotherapists, pain medicine physicians, nurses, psychologists, sex therapists, pharmacists, social workers, and importantly as well, administrators. I'm just going to take a moment to focus on psychology for pain, because there are a lot of misconceptions about why psychology and psychological approaches are involved within a pain management program. The biggest one, of course, is that pain is somehow imagined or exaggerated or made up or psychogenic, or the result of a mental health disorder. The second is that psychologists are purely there to help people manage the distress associated with the experience of pain or trauma from the injury, or teaching people just how to live with or accept pain. And we absolutely do help people with managing distress and learning to live with pain, but the primary aim of psychologists or nurse therapists working in pain teams is actually to help the patient and the team to understand that really complex interplay between the cognitive, emotional, physiological, and behavioural elements that may inadvertently be maintaining or contributing to increasing nociplastic upregulation, as well as the cognitive, emotional, physiological, and behavioural elements that could also be increased or introduced to contribute to increasing nociplastic downregulation. So again, we're thinking about that volume control. And it can be very difficult, though, for patients to want to engage with psychology for pain if they feel it's because they are being psychologized or fobbed off, or not being taken seriously, or that they're too hard to fix. So it's really important if you can help orient patients as to why this role might be helpful, because people often hear the idea that because the brain is involved in pain processing, or that a psychologist will be involved, that they are somehow consciously or unconsciously doing pain to themselves. And that is no more the case than the beating of your heart. Yes, we can influence it over time, but you can't will your heart to stop beating or start beating. And just a quick note, there's no such thing as a pain psychologist in New Zealand. That is not a specific scope of practice or accreditation, nor is a pain therapist. So whilst psychology training is very rigorous, there is no guarantee that this has included any education about pain or working within a pain MDT. Other really key players in pain management teams are our physiotherapists and our occupational therapists, depending on patient need. And these clinicians are really involved in working on neuroplastic change and increasing confidence by doing. So they won't be using the hands-on approaches that are often used in acute physiotherapy settings, such as massage or acupuncture, or using aids such as taping or braces, or helping people with different work equipment, even though they sometimes can be useful. And this different approach can be quite difficult for some patients who are used to a more hands-on physiotherapy approach, or who are expecting a more hands-on physiotherapy approach to help manage their pain. But again, we are really looking to remodel the nervous system and empower patients. And this is best done with self-management and doing approaches rather than done to approaches in the context of nociplastic pain. And for those experiencing pain in the pelvis and continence problems, a key team member will also be pelvic health physiotherapy, which is a different scope of practice again and is a specialism.
So one of the questions we were asked to cover in this talk was, so when should patients be referred to a pain centre? Sadly, pain management centres are often seen as the last resort. Everything's been tried and nothing else has worked, so let's send you to the clinic of last resort. But we would really much rather see people who live with pain or who are at risk of developing pain following surgery much earlier in their journey to try and mitigate the consequences of persistent pain, or to look at a preoperative prehabilitation program to try and optimize surgical outcomes. We'd really much rather be the fence at the top of the cliff than the ambulance at the bottom. We do absolutely, however, recognize the funding and systems challenges which do get in the way of this. So speaking of referrals, let's review and reflect on some patients. Now, a reminder, these are not real patients. They may have composites of many who we have seen.
So we hope that the following patient examples typify some of the common pitfalls that we've seen, and also reflect some of the journeys of the people who have been harmed by mesh, to help us sort of understand what maybe they've been through. This might be something they can relate to. So my first example is Mrs. A. She developed symptoms after mesh insertion, but was told that these symptoms weren't related to mesh. And she was also told by one health professional that she interacted with that they'd had mesh and it wasn't causing them any problems. So the mesh probably wasn't the issue. They were probably trying to be empathic and help her along, but actually she heard that as the problem is me. She was referred to a single clinician pain program with a physiotherapist, but this seemed to aggravate her symptoms despite her discipline in doing the exercise she'd been given by the physiotherapist, until she finally did see a surgeon who recognized that mesh was the issue and promised that the removal was all that she needed to improve her symptoms. The mesh was able to be removed without too much complication, but the symptoms didn't resolve. And ongoing pain made rehabilitation really difficult, and Mrs. A began to experience increasing fatigue on top of her pain. And this really starts to impact how she feels about herself. She continues to worry that mesh may still be inside of her, and given her initial experiences of repeatedly being told that mesh wasn't the issue, only to find out that it was, she finds it hard to trust this. Her surgeon then discharges her as there's nothing more surgically that they feel can be done, and she feels really abandoned by the medical system and reluctant to engage with allied health support, as she sees this as, again, just being fobbed off, and also not what she really needs, given that she's still worried about mesh being inside of her. So Mrs. A typifies many of the patients we see whose journeys are experiences of time and time again being given hopes of finding a reason and therefore a cure for their symptoms, only to have their hopes dashed and be discharged by those services, over time eroding their faith in the medical system and increasing the patient's sense of isolation, hopelessness, and distress. Many of our patients describe this as being a real roller coaster. Unsurprisingly, these patients are weary, distressed, sometimes angry, and are often sick of telling their story when they meet with health professionals. And sometimes this can make and this is sometimes obvious in their presentations, which can lead to negative encounters with health professionals. Researchers have described a vicious cycle where negative interactions with the health system lead women to feel mistrusted, blamed, and doubting their own symptoms, which of course results in increased distress. Women with medically unexplained pain and other symptoms are less likely to be taken seriously, seen as malingerers, and their pain attributed to psychogenic causes or simply non-existent, they're just making it up. They are less likely to be prescribed pain medication and more likely to be prescribed antidepressants or given a mental health referral. Research also shows that women are mistrusted when they look too good or if they don't look good enough. The more that pain is accompanied by distress, the more psychological factors are attributed to the causation of the pain, which often just serves to confirm the emotional woman stereotype, further resulting in the tendency to minimize or psychologize pain symptoms at consult and increase distress and worry. And if we go back to the idea of the different things that might be contributing to ongoing pain, increased distress and worry and invalidation all fit in that category.
So thinking of another pitfall that we commonly see. As these pain diagrams show, the repercussions from surgical mesh can lead to a wide variety of symptoms in many different body areas. And as Jessica has described, many women have experienced being told that their specific symptom can't possibly be from mesh. But it is also important to keep a balance and keep an open mind and not assume that every symptom is because of mesh. So let's review some examples. So Miss B had a complex prolapse mesh repair 10 years ago and has had ongoing problems with pain and voiding since. She's waiting to have removal surgery, but there have been delays for various reasons. Over the last 6 months, she's had a change in bowel habit and crampy abdominal pain, but this has all been attributed to her mesh until she attends her pre-surgical MRI. But this is not her images, but this is what you find if you Google MRI bowel cancer. Another patient, Mrs. C, was referred to us 2 years after removal of her mesh with widespread pain and terrible fatigue, such that she's spending much of the time in bed. She's got really severe urinary frequency and nocturia, which is worsening her fatigue. She's also known to have 30 kilos of unintentional weight loss, which is attributed to her chronic pain. Imagine a number of you in the audience are sitting up and thinking, I certainly was. So I arranged a selection of blood tests, all of which were normal, apart from an HbA1c of 118. So her weight loss is now stabilized and she feels much better on insulin. Another patient, Ms. D, was referred to us with a complex persistent pain and PTSD following complications after both insertion and removal of a TVT. She's developed an incisional hernia, but the current plan is conservative management until her pain and mental health are better controlled. She's been given appropriate safety net advice that if there are any signs of strangulation, she should go to ED. But when she does have an episode of worsening pain, abdominal swelling and vomiting, and her sister calls an ambulance, she declines to get in because her previous experience in ED was being treated as just having post-op chronic pain flare-up, when in fact she had a large pelvic hematoma that needed a blood transfusion. So as with all patients, any new symptoms should first be reviewed for red flags. But something we hear from many of our patients who live with persistent pain of any type is, if you're in ED, once they hear you have fibromyalgia, endometriosis, mesh, everything is just attributed to that. So one of the things that we did with Mrs. D was to draw up an acute care plan together. And this is the template that I use for all of my patients who live with pain, and you're very welcome to screenshot it and use it to make your own version. One of the key points is the importance of ruling out red flags, and that as this can be tricky, senior oversight is vital. Clearly, we modify it for each person, and Mrs. D has added a statement about how coming to ED is very triggering for her, and the strategies, both psychological and pharmaceutical, that work for her.
A key theme that we are seeing with these patients is simply not feeling listened to, and often the psychologizing or writing off of symptoms, resulting in mistrust and distress associated with the medical system, or worse, important symptoms being missed. The very system that is supposed to help them has harmed them, and by looking at a single symptom through a singularly acute and biomedically focused lens and not the whole person, inadvertently continues to harm them because fixing people has taken precedence over listening and connecting with them. Validation does not mean we have to agree with patients about what they should be prescribed or what their symptoms are caused by. And it doesn't mean if we hear their distress that we have to be able to fix it. Rather, to validate someone is to acknowledge and accept their feelings, thoughts, and beliefs, and not question these. Validation involves expressing understanding, legitimacy, and acceptance of another person's experience. Validation doesn't attempt to alter or argue with that person's experience. Just accept it as it is and let that person know that you have heard it. And listening to patients and validating their experience is not just a nice thing to do, it has a demonstrable physiological effect. Research shows that in stressful situations, invalidating someone's experience of their difficulty actually increases negative affect and sympathetic arousal, whereas validating their experience has the opposite impact. And this same mechanism is also true of people's experience of pain. Therefore, patients provided with validation are able to feel calmer, they're able to feel heard and supported, and are in a better place to be able to make decisions for themselves from a place of calm rather than desperation or distress, which often means less distress and increased calm for clinicians as well.
So it's really not surprising to me that we see so many clinicians struggle with managing persistent pain, as beautifully summarised here by the now Dr. Elspeth Shipton in her PhD thesis. Pain education in medical schools locally and internationally is really lacking. On a recent trip back to the UK, I cleared out 5 large boxes of medical school notes from my parents' attic. And throwing through these thousands of pages of papers, this was the only mention I saw of pain. 5 years and just these 3 pages, of which one is all about epidurals. I do vaguely recall mention of the gate control theory as being groundbreaking, and no, I did not go to medical school in 1965. I don't think I was aware of the importance or even the names of the different types of pain until I started my FPM training. But this really is key, as you do need the right diagnosis to direct the right treatment. Most with pain following mesh surgery will have a mixed phenotype pain, but often there is one pain type predominating. As a result of this lack of understanding, I see lots of people who experience burning pain. And so this just gets labelled as neuropathic. But I can tell you when I go to the gym, my legs really burn, and I'm pretty sure that's not neuropathic. So how do we diagnose neuropathic pain? Well, the diagnosis under IASP was tightened up in 2017, and there's this really nice flow diagram which helps us walk through it. So the first thing we need to look for is there a history of a relevant lesion? And certainly consequences of surgical mesh injury, surgical mesh insertion or removal can lesion the nervous system. This can be a direct nerve injury, transection, or tension. And to answer the next question, you need to have a really good understanding of the neuroanatomy, which within the pelvis is complex. There is somatic and autonomic innervation, multiple overlapping fields, and anatomical variations. And different mesh products can be put in different locations, including sometimes places they were never meant to be. And the surgical approaches to remove them are also variable. And in addition, nerve sensitization muddies the picture further. We'll look at that more later. So let's look at a couple of examples. So Mrs. E presented 2 months after TBT insertion with his parunia, male penile pain, and on examination was found to have a small area of mesh erosion in the midline. This was locally excised and the edges closed. But unfortunately, she went on to have multiple repeated episodes, different areas of the mesh exposing, and this was treated again with local excision, and then needed ongoing long courses of antibiotics for repeated infections and a sinus. Finally, all of the mesh is removed. But sadly, despite this, she has ongoing severe pain involving both lower limbs and a range of constitutional symptoms. And she was really highly disabled, unable to walk very far and spending a lot of time in her lazy boy. She was seen by a pain specialist and given a diagnosis of pudendal neuralgia. And I see lots of people given this diagnosis, many of them incorrect. But informed by this diagnosis, she undergoes some pudendal nerve blocks. These are done under general anaesthetic and without really any systematic monitoring of effect. These procedures flared up her pain and gave her temporary problems with incontinence. But when she was seen back in clinic 8 weeks later, reported things were settling a bit, and so they were repeated several times over the next year. And she was referred asking me if I thought it was worth trying another one. So to help you understand my response to this, let's contrast this with another patient, Mrs. F. So let's get up the flow diagram. So Mrs. F had a complex mesh kit inserted, which does have some arms which go out to the sacrospinous ligament. So there is a relevant potential lesion to the nerve. And then if we look at her pain distribution, here is her pain diagram. And if we compare this to the textbook, you see this really matches beautifully with the distribution of the pudendal nerve. So this gives her a diagnosis of possible neuropathic pain. Underneath this diagram, Mrs. F has annotated numbness in the right labia. And certainly when I examine her, there is a little semicircle in this exact distribution of reduced sensation to pinprick. And so this gives her a diagnosis of probable neuropathic pain. We then arrange an MR neurography, which I think are the most beautiful scans. And this showed a change in density of the pudendal nerve on the right, giving her a diagnosis of definite neuropathic pain. So whilst like most of our patients, she does have a mixed phenotype pain, it is predominantly neuropathic. So I arranged for Mrs. F to undergo a pudendal nerve block, which was performed with CT guidance, and all my patients who undergo interventions are given a block sheet like this to complete. And this is what a positive block sheet looks like. Pre-injection in the day pain between 3 and 8 out of 10, and post-injection really a real reduction in pain. And so if we contrast that with Mrs. E, who had mesh erosion in a location that wouldn't really be expected to lesion the pudendal or any other major nerve, and her pain does not fit the neuroanatomical distribution of any specific nerve. And so her pain is unlikely to have any major neuropathic component. And so I did not feel it'd be appropriate to try any further blocks for her.
So sometimes the pitfall isn't so much about what we're doing, but about how we're doing it. And working in specialist silos is really a great example of this when it comes to complex and long-term conditions. So let's talk about Mrs. G. Mrs. G is 3 years post-TVT removal when she is referred for an IDT pain program, but she is still experiencing ongoing pain. She's only just started her pain program when she experiences a severe pain flare-up and goes into ED for help. Despite finding no red flags or acutely modifiable cause for her pain, a repeat cystoscopy and MRI are arranged for her. This is really frustrating for Mrs. G. She feels like the pain program has been a waste of her time because she wouldn't be being referred for further tests if there wasn't something to find and fix, so she disengages from her pain program. When specialisms behave as silos and care isn't integrated, decisions made by one team can inadvertently undermine the efforts of others. Understandably, if patients conceptualize their pain as purely nociceptive, which is how we've all grown up thinking about pain, engaging in a pain program that's designed to target nociplastic pain can feel pointless, slow, and frustrating. Of course it does. Which isn't to say that nociceptive contributors shouldn't be investigated and addressed if they arise during the course of treatment, but ideally this should occur in consultation with the pain management team or other teams working with the patient in order to integrate the approaches so both nociceptive and nociplastic contributors can be addressed in ways that doesn't leave the patient throwing the baby out with the bathwater or feeling that they're unable to re-engage if a purely nociceptive treatment pathway doesn't prove to be helpful. And in this day and age, when we have technology and email, communication should be easier than ever. If the patient can wait for an investigation, i.e. is not considered red flag, then there should also be time to take pause and not be afraid to consider next steps with the wider team. What's really important is that this is also communicated to the patient, because this not only reinforces the collaboration as an important part of their whole person treatment, and allowing them to view their healthcare journey as integrated as well, which can help to restore their faith in the system, but it also means they're not left in the dark about what has happened or just feeling fobbed off.
So we're now 55 slides into the talk. How come I haven't started talking about medications? Well, we know that prescribing for pain is often complex, but there's also new research coming out each year, including quite a number of negative trials recently, refuting what has been common knowledge for a generation. For example, in the last few years, there have been RCTs showing that gabapentin for chronic pelvic pain and both antidepressants and antiepileptics for low back pain are in general no more effective than placebo. And we know that medications can also cause harms. This is demonstrated well by Mrs. H. So Mrs. H had a TOT inserted for incontinence. And over the next few months, she developed severe pain in both her lower limbs, and by the end of the year, had pain in a widespread distribution. She also developed a slew of other symptoms with onset over this time. On imaging, the TOT was found to have a twist in it, so it was removed, but sadly with no change in pain. Mrs. H also was seen by a pain specialist who diagnosed pudendal neuralgia and prescribed pregabalin. As it didn't seem to really be improving her pain, the dose was increased up until it reached the maximum. But when I met her, she still had disabling pain, but also cognitive impacts such that she lost track of her thoughts multiple times during our consultation. Her husband rolled his eyes and told me how this happens all the time at home, such that she's banned from cooking after nearly burning the house down, leaving a pot on the stove. She wondered whether perhaps the pregabalin might be contributing to this, but when she tried to stop, she had what she described to me as funny thoughts. So what followed after that is more than 3 months of a slow weaning program with intensive psychology and medical support. And this has been an incredibly difficult journey for Mrs. P, with sleepless nights, volatile mood swings, intrusive and at times suicidal thoughts. And she describes that through this time, her life has really been in limbo between this discontinuation syndrome and her severe pain. She's not really been able to partake in rehabilitation or family life. Doesn't stop ACC asking when she's ready to go back to work. Now we have her completely off her pregabalin. She finally has a clear head. She's discovered she can do crosswords again and told us that she's discovered Wordle. But interestingly, her pain is no worse. And now we can finally make a start on active rehabilitation. So I hear from some of my GP colleagues that the Lyrica reps painted them a picture of a safe, non-addictive, broadly effective non-opioid pain relief. But I think it's also worth noting that Pfizer has paid tens of millions of dollars to settle lawsuits over misleading advertising. I quote, "Contrary to the approved intended uses, Pfizer marketed Lyrica for the treatment of chronic pain, neuropathic pain other than diabetic peripheral neuropathy and postherpetic neuralgia, perioperative pain, and migraine." But as summarised here by the Cochrane group, and this is the same for gabapentin, the supporting evidence for gabapentinoids is really only there for peripheral diabetic neuropathy and postherpetic neuralgia. And for other neuropathic pain types, there is either no evidence or, as in the case of radiculopathy, evidence of effectiveness. Common side effects from the gabapentinoids include drowsiness, dizziness, memory problems, cognitive clouding, impaired balance, mood disruption, including suicidal ideation on both initiation and discontinuation, weight gain, fluid retention, and gabapentinoids potentiate opioids, which increases their risk of OIVI and death. Not that many women who have surgical mesh will be planning further pregnancies, but I am seeing increasing prescription of gabapentinoids in young women, and so it's worth being aware that these are not recommended in pregnancy. Internationally, there's also increasing evidence of gabapentinoid misuse. And again, not that I think my patients are misusing their medications, but having a drug in the home that has a street value does bring other risks. And as seen with Mrs. H, gabapentinoids can come with a really difficult discontinuation syndrome. So another drug that I'm seeing increasingly prescribed is compounded vaginal diazepam. This seems to be happening particularly in Auckland, and I'm not sure the origin of this trend. The belief seems to be that it will treat pelvic floor spasm. However, this doesn't make sense, as diazepam works on GABA receptors, which are located in the central nervous system, i.e. the brain and spinal cord, and not in the vagina. So any effect seen must be systemic, as it is absorbed into the bloodstream, just as it would if it would be given orally. But of course, this does carry a number of significant risks. There have also been a number of trials showing that this treatment does not improve high-tone pelvic floor dysfunction. And so the NICE guideline recommends against its use. So going back to Mrs. H and Mrs. E, they both have widespread areas of pain and score highly on the central sensitization inventory. And so after a thorough workup, it's clear that they both have predominantly a nociplastic pain phenotype, i.e. the bulk of their symptoms are a result of sensitization of the nervous system. And medications are not good in this situation. What they need is an interdisciplinary program with a graded reactivation and a graded desensitization approach.
Sometimes a pitfall occurs when we fail to incorporate the person in front of us into their treatment plan. So Mrs. I provides us with an example of that. As a child, she was subjected to experiences that prevented her from developing the tools she might need to advocate for herself well, and left her with a legacy of trauma, including experiences of dissociation when she was fearful, such as during internal pelvic examinations. This really raises issues about her ability to give consent in these situations, such as when she's going for routine smears. When she developed symptoms following her mesh insertion, the required medical examinations that she was required to undergo for her care inadvertently proved to be experiences of re-traumatization. And in an attempt to protect herself, she tries to both make her voice heard and escape from further re-traumatization, and is labeled a difficult or heart sink patient. The added impact of injury done to, What we know is that 1 in 4 women will experience a sexual trauma in their lifetime, and 100% of those harmed by mesh have experienced a medical trauma. Trauma can be historic and intergenerational, long-standing or recent. And for some patients, like Mrs. I, there is layer upon layer of trauma. Trauma can impact people's ability to stay present and regulated during their medical appointments, and even impact their ability to attend those medical appointments, and certainly their ability to receive important information about their health choices and make a real informed consent. So using a trauma-informed care approach recognizes the difficult experience that patients have been through and works to prevent further harm. This might mean simply providing information both verbally and in written form, encouraging support people to attend appointments with them, including sensitive claims counsellors as part of the whole person health team, and making sure that there is space between the time that people are given information and expected to give consent. And we've got some really good resources at the end if you need to access more information about trauma-informed care. But we also want to acknowledge that working with and hearing the stories of those who have suffered can be very hard on clinicians as well. And one of the pitfalls is when clinicians are not adequately looking after themselves, or putting the oxygen mask of others on first before themselves. And Dr. Yu is an example of this. Dr. Yu felt that the medical system was utterly failing many of her patients, and she felt a sense of responsibility for these harms because she was also part of the medical system, and a strong desire not to repeat those harms in her practice. And this situation was not at all helped by increasing pressure within the medical system to do more with less. And in a society that had given Dr. Yu the message that if she worked hard enough, she could succeed, she had also taken on board the message that if she didn't succeed, that was because she hadn't worked hard enough, which meant that she only worked harder. When you're so focused on taking care of others, it's so easy to forget that your first responsibility really needs to be for yourself, because it's through your attitudes and well-being that you're able to provide the best care to others. That includes your patients and your loved ones. This includes developing an awareness of the thoughts, behaviours, emotions, and even physiological responses that we have to the situations we find ourselves in, and how those patterns can impact our long-term well-being and ability to do no harm to our patients. MPS provides a minimum of 6 supervision sessions a year, and I strongly encourage you to take advantage of those and see them as an investment in both your own self-care and your ability to sustain a career and provide care to patients across the course of your career.
So we're very well aware of the privilege that we have, that our first appointments are well over an hour long, and that our GP colleagues get at best 15 minutes. So what can be focused on during this short time? Well, I think it's important to just keep things simple. So the approach that I use whenever I see any patient living with pain should feel really familiar to any GPs and physiotherapists watching, as it's the same approach that we use with back pain. Firstly, we want to identify and manage any immediate red flags, for example, infection, urinary retention, acute suicidality. And to be aware that as well as diabetes, I've recently found a few undiagnosed chronic renal failure, an IBD, and one metastatic cancer. So again, keeping eyes and minds open. And then we want to move to yellow, where we want to gain a wider whole person understanding of our patient's situation before we can look to green. What can we make a start with today? So one of the ways to try and gain this broad range of information in such a limited time is to ask your patient to complete and return a questionnaire. These 3 are available online. None are perfect, and so you may know of a different one that you prefer. Many of our patients have also drawn up a timeline of their surgeries and procedures and very detailed records of their symptoms, which they may well be very happy to share with you.
So here are some actually pretty simple steps you can take in your practice to help patients feel validated. So listening to the patient's concerns, validating what they tell you, equipping them and yourselves with education, support and resources, and referring if you need to. The GPs that patients describe to us as being the great ones are really the ones that make them feel heard. They don't need you to be able to recite a complete list of all types of mesh or do a robotic assisted removal in your consult room. And they're not even expecting you to fix them or perform miracle cures. What they want and often really need is the skills that you GPs are using on a daily basis: hearing, listening, believing. But in the time-pressured environments of GP land, it can sometimes feel that this really isn't an option. And as a result, it can feel really daunting to ask questions and feel without feeling that we're opening a Pandora's box and won't have time to pack it back in again. So it's really important to remember that listening doesn't mean you have to fix. And interestingly, research shows, and some of you may be familiar with this research, that if asked an open-ended question and left to talk uninterrupted, the mean duration of spontaneous speech by patients is just 92 seconds, with the median duration of just 59 seconds. And 77% of the 355 patients included in the study finished their entire statement, everything they had to say, every complaint that they wanted to talk to the doctor about within just 2 minutes, with only 2% speaking uninterrupted for more than 5. Despite this, other research shows that physicians interrupt or redirect their patients on average after just 18 to 23 seconds, and that shorter consult times are associated with higher rates of drug prescription and follow-up appointments, and less discussion of health promotion and health prevention activities. And as I discussed earlier, validation is such a crucial part of both helping patients to feel heard and also helping to soothe distress and sympathetic arousal, which can help with rebuilding trust and relationships within the health system, which is so important for those who have been harmed. Again, validating doesn't mean you have to fix, and that includes distress. If someone is tearful or angry about their experiences, well, given the examples we've heard today, I think we can all agree that that's more than understandable. And being allowed to express those emotions without swooping in to fix them or trying to defend the system is really an important part of having those emotions and therefore those experiences validated. Using validation effectively begins with being present both with one's own emotion as well as with others. So sometimes if we're uncomfortable with other people's emotions, this can inadvertently lead us to invalidate the other person's experience. So learning to sit with other people's distress and our own distress is also important. We also don't want to inadvertently invalidate somebody's experience by suggesting they shouldn't or couldn't have that much pain based on their presentation. It really isn't our job to tell our patients what their experience is or should be. Telling somebody what is not wrong with them can also be inadvertently invalidating, as often people hear that if the thing that you're looking for isn't wrong with them, then it's something wrong with them in terms of it's psychological or in their head. So make sure you try to focus on a positive diagnosis, that is, tell them what is wrong with them. You have a persistent pain condition. And if it's not your scope of expertise to diagnose or treat, that's okay too. Let the patient know that you are there to help get them in front of the people that can, and that you can assist with the coordination of that care and will continue to be involved as their healthcare home, so they don't feel like they're being fobbed off or that they're too hard to deal with. It's just that we all have different scopes of practice, and this is the way the system works. And then equip them. They don't need to go away empty-handed. Often there's lots of things that we can be targeting that are really helpful, such as difficulty with sleep or stress management. So focus on what is most important to the patient. Provide education about pain if you feel confident to do so. Provide them with resources, and we've got a stack of them at the end of this talk that you can refer them to. And then you can provide additional supports if required, such as further counselling or seeing your health improvement practitioners if your practices have those. And if you do decide that you need to refer your patient, be really open and transparent about your referrals. Help orient your patient as to why you're referring them on, especially if you're referring them on to a psychologist. But help them provide that consistency and reassuring them that you stay their healthcare home. And then also give them permission to keep you in the loop. And that will help with the communication through NDT that I was talking to you about before, but also that it demonstrates to the patient that you're still interested and that you're still part of their healthcare team. And so just let them know how they can keep you in the loop. Can they email? Can they ring and leave phone messages? Let them know what will work best for your practice.
And certainly, if you're going to make a referral on to a pain physician, please don't set the expectation that we have the magic fix-it pill. Hopefully, I've made it very clear through this talk that medications have, at best, a very minor role in treatment. And whenever we do prescribe, we need to be very careful to not cause any further harms. Many of the medications that are used in persistent pain are off license, and so it's important that patients are given adequate information and time to consider and ask questions before these are prescribed. Shouldn't be medications first or only for either pain or for mood. Patients with surgical mesh harms are commonly prescribed medications for pain, for overactive bladder, and for low mood, often by different prescribers who may not communicate well with each other. And this is also a patient population with very high levels of distress, low mood, and suicidal thoughts. And so shorter dispensing intervals might also be appropriate. Where possible, topical agents are lower risk than systemic. And if we're going to start a medication, we should start one thing at a time, because if 3 things are started at once, we don't know what's helping or bringing side effects. And if we're going to prescribe, treat it as an N=1 trial, titrating the dose up, slowly monitoring effect and side effect. But when we're looking at effect, we want to see, is this helping the patient progress towards her valued goals? Is she sleeping better, walking more, tolerating car rides better? Not as it's reducing pain scores. We want to stop any medications that do not help. I spend more time de-prescribing than prescribing. If I see a patient that's on 12 different medications and yet still has disabling pain, that tells me that those medications are likely not effective. One of the things I spend time doing with my patients is to empower them to state to other clinicians why they're not taking certain medications. So, for example, when patients go to ED with a flare-up of their pain, the triage nurse will often ask, well, have you taken a Panadol? And an empowered patient can say, no, I haven't, because I have neuropathic pain and paracetamol does not work for that. Even when we find a medication that is helpful, we want to periodically review it every, say, 3 or 6 months and consider whether it's a time to start trying to slightly reduce the dose, with an aim that most people will not be on medications in the long term. We do need to be very careful with any medications that come with a discontinuation syndrome and do this in an informed way, slowly and with support. We also want to make sure that we're not just thinking about their pain. We want to look at the other comorbidities that these patients present with. And if you feel a pressure that every consultation needs to conclude with a prescription, then consider a prescription for non-medication input, for example, online CBT, to see the counsellor, health coach, or for gentle exercise. So before you even consider prescribing a medication, you need to think about what types of pain we're treating. But remember, most will have something of a combination. If there is active ongoing nociception, so for example, current infection or inflammation, then you can consider trying paracetamol or NSAIDs. If there is neuropathic pain, as per the flow diagram earlier, you could consider a trial of low-dose TCA, or in the fully informed patient, a trial of gabapentinoid. However, recognizing that the vast majority will get no benefit from either of these, and in which case that they should be ceased. And for those with nociplastic pain, medications really have very little benefit. Looking at the evidence base for fibromyalgia, which is the poster child for nociplastic pain, tricyclics might help a few, but do come with risks including sedation, Falls, dry mouth, urinary retention, constipation, and in long-term use, increased risk of dementia. These are also drugs that are very high risk when taken in overdose. Those with bladder pain, you could consider a tricyclic or antihistamines, but be aware that education, stress management, and physiotherapy is better supported. And for those with vulvodynia, the only treatments with good supporting evidence is CBT and pelvic health physiotherapy. Again, whenever we prescribe, I remind the patient that this is just one small component of the overall care. I use this infographic at the end of all of my appointments to explain to my patients the different components that we're going to make a start on today, and medication might just be one small component of that. Also can recommend this website, which is again in the resources coming up, which also is from Sydney, and this walks you through how to develop a primary care pain management plan. Walks you through step 1, looking any red flags, and step 2, any psychological red flags, and so on. And then we'll draw you up a pain management plan at the end. So as promised, we have many pages coming up of different website resources. So if you get ready with your screenshot, or you can always watch this back later. So these are some good resources for clinicians to upskill. The first 4 of these do come with a cost, but do also come with a certificate. For resources for providing pain education for patients, these are all online and free and freely available. Looking at online pain management, there are a range of online programs, including some free prescribable online pain CBT, and you write a prescription for this for the patient, and it allows you to monitor to see whether they are attending the sessions. Some options for mental health support, many of which will be familiar to GPs already. Options for managing sleep, again, free and freely available. And for those who are looking for upskilling in trauma-informed care, I can strongly recommend this top link, which is a free online trauma-informed care course, which comes with 2 hours of CPD and is really very good. The next link is for patients who want or need to access the sensitive claims pathway. And of course, there is always information about assessment and referral and health pathways, which is updated over time. But do be mindful about capacity and setting realistic expectations. For any patient who has an accepted ACC claim, so that includes mesh patients or patients with any kind of injury, clients are eligible for a pain management service if they've had persistent pain for 3 months or longer from the date of their covered injury. But I will point out that you cannot refer directly to a pain medicine physician. I'm going to underline this because we do receive quite a number of referrals that we cannot accept directly because there is no funding pathway for that with ACC. If you want to refer to a pain physician, this can only be done directly by ACC or from clinicians within a pain program. You can't refer directly into a pain program, but what you can refer for is a triage assessment, and you use an ACC 6273, which you can find online, and this link will get you the list of all of the providers. And the outcomes of this triage could include a community or a tertiary level pain program. There are currently community level providers in all regions, but just 3 tertiary services: Auckland Regional Pain Service, Wellington Hospital, and in the South Island, the Australis Specialist Pain Clinic, where Jessica and I contract at the moment. And for patients who are accepted onto a community level pain program, those clinicians can access tertiary support from the tertiary services as needed. There are quite a range of other ACC contracts and programs, and this can be a little bit of a maze. And so sometimes if it's complex, it's best for the patient to see if they can arrange a chat with their recovery partner, which is the new term for case manager, about the different services that are available. And returning to the beginning, this webinar came about following an action point from the restorative justice work. And another action point was for the development of specialist MDT mesh services. And so hot off the press, I have this statement from the Te Whatu Ora team. A new national MDT service is being developed and will become available in the next few months. Announcements will be made, including via health pathways, to let you know when referrals can begin.
Thank you both so much for your presentation. So really very interesting, but very quite complicated talk to go over and topics. So a couple of questions that we've come in. One was just talking about the NDT or IDT in terms of managing pain, what's the role for kind of spiritual aspects or a spiritual chaplain or leader in this?
Absolutely, that can 100% be part of the team. Again, it's really about thinking about the patient in front of you and including what is important to them. And the best person to ask is your patient, but absolutely anybody can be part of that team. That's important to the worldview and the patient. And certainly we talk about treating the patient, but actually the wider system, the family as well, definitely really important as part of the care.
And definitely IDT care is never cookie cutter. It's not one size fits all. It's about assessing what is most important and most appropriate for each patient.
Thank you. The term central sensitization, where does that fit in?
So nociplastic pain is a descriptor from the IASP to describe the clinical phenomenon that we see of pain that is related to or explained by upregulation of the nervous system. Whereas central sensitization is the mechanism behind that. So very much related, but just different components of the same thing that you see.
Sure. And the points that you made in terms of what we can do in primary care, validating the concern, talking about referrals, things like that. It sounds like that's something that you could use more broadly, like not just for mesh patients, but kind of chronic abdominal, chronic pelvic pain patients as well.
And again, every patient is an individual, and the different types of pain and the different journeys that people have walked to get to our door will inform and modify that assessment that we make. But absolutely, this overall approach of an individual assessment of the whole person and all of the contributors to their current situation, and looking at ways to address those different contributors can be applied to all sorts of pain.
From a primary care point of view, when we're looking at referring, is it helpful in terms of triage information if we have trialed some different things like different medications for you for when they reach the next kind of step in the service?
So certainly, if the patient has had if the GP has been able to have a good conversation with the patient and make an assessment of the different contributors to their current situation, and been able to have a conversation with them about the different options which are available, recognizing that what can be done in general practice is not always the same as what can be done in specialist services. And after a full discussion, if an informed patient wants to make a try of some of those options before they come to see us, then absolutely that can have crossed some things off there. But equally, some patients say, look, this is a lot of information and I feel a bit overwhelmed, and I really want to be able to get a specialist assessment before I try those. I think that's also absolutely reasonable.
Okay, well, those are our questions. Thank you both. Thank you both again for taking the time to present to us this evening. To our viewers, thank you so much for joining us tonight. So have a lovely night, everyone. Thank you again.